Dr. Sarath.
Yes, sir, you are audible, sir.
Yes,
Good evening.
sir.
Yeah.
Audible,
Okay.
sir.
Okay. I also would like to welcome Dr. Jadon sir, Dr. Ashok Jadon sir, Dr. Sahu, Dr. Bhanu Pratap Swain, Dr. Rishikesh Jha, and all our esteemed member of the BJSA. Now, Dr. Sarath, now you may start our CAB.
Thank you
Dr.
very much, sir.
Sarath.
Yes, sir. Thank you, sir. Thank you for your kind words, sir. And now I invite our chief guest, Dr. Sabyasachi Das, to say a few words.
Hello, good evening, everyone. It's a nice opportunity for me to address this August gathering. I was personally interested in USG for a long time, since 2013 onwards, and I presented one presentation in Dhanbad conference. So this is needless to say that this is the most important weapon for an anesthesiologist or a medical graduate, and stethoscope is perhaps getting replaced by this new device, though it's not a new thing, but in anesthesiology domain, like lung ultrasound, or these are the new things which are coming up very soon, and it's practiced all over. So it's basically art. It's not a machine dependent thing. It's basically operator dependent. Interpretation is more relevant. So I hope everybody will enjoy as well as appreciate the nice presentation by the presenters. They are from reputed places, and I hope they will present their enrich all of us. Thank you.
Thank you very much, sir. Thank you very much, sir. And we are happy to have you as chief guest in the BGSS CME, sir. Thank you very much, sir. And now we will start the session. I would like to invite our moderator, Dr. Ashok Jadon, sir, and Dr. Rajendra Sahu is also joining. Let me see. And Dr. Jadon, sir, you can start. During the meantime, Dr. Sahu will join. I have forwarded all the CV to you. And the first speaker is Dr. Bhanu. Please start, sir.
Yeah. Good evening, everyone. And this is really a great opportunity through this BGSA platform where we interact and learn. And at the outset, I must thank Dr. Sharad and the whole BGSA, our chief guest, Dr. Das, and our president, Dr. Dinesh Singh, and all the listeners. And I would like to welcome my colleague, my very esteemed colleague, Dr. Rajendra Sahu also. He has just joined. I could see him in the video. So without wasting time, I would like to introduce our first speaker. As you all know, Dr. Sharad already has informed everyone that this session particularly is dedicated to ultrasound. So we would like to discuss all the facets possible. We can't discuss everything, but the two most important aspects of day-to-day anesthesia practice we will discuss. So I am quite privileged to introduce our first speaker, Dr. Bhanu Pratap Swain. He is a very young, dynamic anesthesiologist, keen interest in pain and ultrasound. He is one of the colleagues in Jamshedpur who picked up ultrasound at early stage and doing very well. He is consultant anesthesian at Tata Main Hospital, and he will be speaking on the basics of the ultrasound to know different like how to interpret, what are the knobs, how it functions. So I would invite Dr. Bhanu to take over and enlighten us with all the basics, knowledge of the basic ultrasound. Yeah, Dr. Bhanu.
Thank you, sir. Good evening to all who have joined. And just give me some time. I'll just share my screen. I think my screen is visible to all. Jadon, sir?
Visible.
Yes, visible.
Yeah. Thank you. First of all, I'm really glad. I'm thankful to the BJSA, especially Dr. Sarath, to give me the opportunity to be a part of this CME. And I'm really glad that I'm presenting one of my favorite topics, that is on ultrasound and how it is helpful to anesthesiologist. And one thing that I will say that today, if you are not using ultrasound in your day-to-day practice, you are not doing justice to your patient, because it brings in so much of convenience, safety, and more importantly, it removes the objectivity, I mean, subjectivity of any procedure that you do. It brings in a lot of objectivity. You see and you decide. And in today's litigation world, I think ultrasound will provide you the evidence that what you are doing is doing right. So not wasting much of time, I will start with my topic, which is pretty basic about ultrasound. And I will be talking about the physics of ultrasound. Then I'll gradually move on how ultrasound interacts with different tissues and different images are created. Then I'll talk about different modes and probes, common terminologies which are used. Then I'll talk about how you're going to optimize your image by using different knobs of ultrasound, which is knobology. Then I'll talk about the probe manipulation, and I'll end my we'll talk about different artifacts in the image. So as you all know that ultrasound is basically uses the sound wave machine that uses sound wave to create the images. And as you all know in our school time, that sound wave needs a medium to move, and it moves by creating compressions and rarefaction in the medium. That means high pressure and low pressure zones. So that is how it is. All this is pretty basic, and that is how the sound moves from one place to other. Now, ultrasound is, if you define ultrasound, is basically the frequency is above the audible range, that is above 20,000 hertz. But clinically, in diagnostic ultrasound, we use 2 to 20 megahertz. That is the frequency of the clinical ultrasound that we use. And as you know, that ultrasound is not only used by us. It is used by the animals, the bats, whales, and even the submarines. And they also use ultrasound. They send a sonar and they detect the returning sound wave. And by that way, they detect the position and the movement of the object in front of them. Similarly, the ultrasound probe that we are using, that sends a ultrasound beam that hits the object, and it returns back and is detected by the same probe, and it is processed into the image. But the question is how this probe is actually creating an ultrasound wave. For that, what we have to do, we have to open up the probe to see what structure is there which is actually creating this ultrasound wave. So when you open up, there are so many structures, but the structure which is important to us is the piezoelectric element, which has a very specialized property called as piezoelectric property. And what it states that when mechanical stress is applied to this special type of element, that creates electric charge. And in reverse, if you apply electric charge to this object, there will be mechanical deformation of this element, and they will vibrate and create sound waves. So this type of material is used in our probe, so that our probe both receives a sound wave and also creates a sound wave. So what are the structures which actually have this piezoelectric property? These are quartz, topaz, lead titanate, and lead zirconate. Lead zirconate is probably the element which is most commonly used in our ultrasound probes. Now, these are different properties of ultrasound wave. I think we have learned all this in our school. I'll just recapitulate. So frequency is the number of cycles per second. That is number of, as I've told already, that sound wave moves by high pressure and low pressure changes in the medium. So it is the number of high pressure and low pressure cycles in 1 second. Now, what is wavelength? Wavelength is basically the distance between two identical points, that is in between two high pressure areas or between two low pressure areas in a waveform. Now, frequency and wavelength are related. Frequency and wavelength are inversely proportional. That means if the frequency is high, obviously the wavelength will go down, and if it is low, the wavelength will be high. Now, what is amplitude and acoustic velocity? The amplitude is a measure of the maximum height of the wave. So, and acoustic velocity is the speed at which sound wave travels through a medium. You can calculate acoustic velocity by multiplying the amplitude with the frequency. Now, as you see that the speed of air is different in different tissues. As the tissue becomes denser, the sound actually the sound moves faster in those materials which are more denser. As you can see in bone, it is 3,360, and in air it is 331. Now, acoustic impedance, it's a very important I think parameter because it has a lot of clinical importance. So it is defined as basically a degree of difficulty demonstrated by a sound wave being transmitted through a medium. You can calculate it by multiplying density of the medium with the speed at which the sound wave passes through this medium. So it depends upon the density. So the clinical importance is that the image that is created by the ultrasound depends upon the returned echo, that's the returned wave. And the intensity of this returned echo is dependent on the size of the impedance difference between the interference between two tissues. As the sound wave hits, because there are multiple tissues in the body, so and there are interfaces. And when the ultrasound wave hits those tissues, there are some of them are returned back, and that depends upon the impedance difference between the two tissues. The clinical impedance, I will come back to it later in my slides. Now, how ultrasound actually interact with different tissues, because this is important because the image that we see is because of this complex interaction. So as you know that when sound wave hits a structure, some of them will be reflected back, some will be refracted, some will be dispersed, and some will be absorbed as well. So, when the sound wave hits, interface two mediums, interface a medium, the angle of reflection has to be same as the angle of incidence. And the amount of reflection actually varies depending upon the type of tissue. And it depends upon, as I already mentioned, that the impedance difference between the two tissues. Right? As I've already told you that air has the lowest density. All of you know it is the lowest density. And also sound wave moves slower in air. So it has got the lowest acoustic impedance. So it reflects the ultrasound wave. That is why we try our best in our clinical practice to remove the air from the interface between the probe and the skin. Because if there will be air, it will reflect back everything, all the ultrasound waves, and you cannot see anything beyond it. So that is the clinical importance of impedance that I have told earlier. Now, reflection can be of two types. It can be specular reflection. It can be a scattering or scatter reflection. Specular reflection occurs from smooth surface. It is in one direction, and that occurs through and smooth surface like needle is one of the smooth surface where there is specular reflection occurs. But most of the body structures, they are not smooth. They are rough surfaces. So there occurs scatter reflection. So there is reflection everywhere. So that is called as scattering. Now, let us discuss about absorption or attenuation, because this is very, very important. So what happens when some of the sound waves are absorbed? But what happens to the sound wave? Basically, that is converted to heat. And that is also called as attenuation. Now, how do you know how much attenuation will take place? That depends upon the attenuation coefficient of that tissue. So basically, it is the estimation of the decrement of ultrasound amplitude in different medias as a function of ultrasound frequency. So what does it mean? So that means that if you are using a high frequency ultrasound wave, that means a high frequency probe, there will be high attenuation. Okay. So that will lead to less penetration because a lot of this ultrasound wave will be absorbed. So it will not travel deep. So there will be less penetration. And I've already told you frequency is inversely proportional. As frequency increases, wavelength decreases. So that leads to, as the wavelength decreases, but that will improve the resolution. We'll come about later in my slide about the resolution. But the point is, if you are using a high frequency probe, there will be less penetration. You cannot see the structures deep, but you will get a very good resolution. The reverse is also true. If you are using low frequency probe, then there will be high penetration, but the resolution will be less. Now, this is a fantastic image that shows attenuation coefficient of different tissues and how the ultrasound wave interacts with different tissues. As you can see, fluid has got a very low attenuation coefficient. Okay, it absorbs nothing, almost transmits everything. So that property is actually used by the ultrasoundologist. We call it as acoustic window, through which they can see deeper structures. Okay, because it transmits everything. If you have got a fluid filled structure or a structure with high content of fluid like liver and spleen, then you can very well see the structures below it. Ultrasoundologists use it as an acoustic window to see like structures like kidneys. They can very well see through the this liver and spleen because they have got a very low acoustic attenuation coefficient. Everything passes through it. And bone, which has got the highest acoustic this attenuation coefficient, it absorbs everything. Nothing goes beyond it. So you cannot see anything beyond it. Again, air, I already told you, it reflects everything, and nothing is absorbed. It reflects everything. So even if air is there and bone is there, they are the biggest enemies of ultrasound. You cannot see anything beyond it. But if a fluid filled space is there, you can see through it. Now let us discuss about different ultrasound modes. I think some of you are knowing it. A mode, B mode, M mode, and Doppler mode are the 4 common modes which are used. A mode is A stands for amplitude. It is the most simplest mode which is used, though we do not use it, but ophthalmologists use it very commonly. They use to measure the length of the eyeball. And what it does, it displays only a single echo signal against time. So usually we don't use this mode commonly, only the ophthalmologist use it just to measure the length of the eyeball. Now B mode, B stands for brightness. In comparison to A mode, in B mode, multiple echo signals are sent and a real-time 2D image is formed. And this is the most commonly used mode that we use and also by the radiologist. Now, what is M mode? M stands for motion, and this mode is used to detect structures that are in motion. Okay, so basically what it does that the structures which are moving in comparison to other tissues, it takes a snapshot. So this is a fantastic example of M mode, where very commonly used by those who are doing long ultrasound. This is called a seesaw sign. When you take a snapshot, you know pleura is continuously moving, and if you take a snapshot of 2D image at one point and you see a structure like this, and you put the M mode, and you'll see a sand-like structure that is long tissue and sea-like structure that is skin and soft tissue, and in between you'll see the glistening pleura. This is called a seesaw sign, and in case of pneumothorax, this seesaw sign is lost. And it is also used in cardiac in echocardiography also. So M mode is a very important mode, and you have to know how to use it. And Doppler mode, as you know, it is based on the Doppler effect. There are 3 types of Doppler mode: the color Doppler, power Doppler, and pulse wave Doppler. Color Doppler simply used to detect the presence and direction of blood flow. When the blood flow is towards the transducer, it appears red, and the flow is away from the transducer, and then it appears blue. Sometimes people get confused that red means artery and blue means vein, but that's not true. It is basically the direction of flow. Now, power Doppler is nothing but it is more sensitive color Doppler, and it is used in detecting low flow states. Pulse wave Doppler, it basically displays the blood flow velocities over time, and you can use it to sometimes to differentiate between venous vein or arterial pulsation also. Now, coming to the different ultrasound probes that we use, there are basically 3 types of probes: linear probe, curvilinear, and phased array probes. Linear probes, as you know, high frequency. I already mentioned they have a low penetration, but they gives very good resolution and have a very large surface area. Similarly, curvilinear probe has a frequency of around 2 to 5 megahertz. They have a high penetration but gives low resolution. Phased array probes are usually used by cardiologists for doing 2D echo, and they have a very small sectorial view because they can peep through the ribs to see the heart. and they have a very small surface area, but have a very
Dr.
good.
Bhanu, Dr. Bhanu.
Yes, sir. Yes, sir.
Yeah, sorry to interrupt you.
Yes,
Actually,
sir.
in between your voice is fading, so please be near to the.
Okay,
continuously
okay,
be
sir.
near
Okay,
to
sir.
the-
Thanks, sir. Thanks, sir. Now, this is whatever probe you use, you have to see where is your orientation of the probe. Where is the orientation marker? Because it corresponds to the orientation indicator which is there in the screen. Okay, so whenever you are using your probe, just see where is the orientation marker and the orientation indicator which correspond to the orientation indication. This is very, very important. Otherwise, you will not be properly oriented and you'll be in trouble. You will not identify the structure properly. Now, there are different ultrasound terminologies which are used, and you have to know what are these terminologies and what is the meaning of it. Echogenic means ability to produce echoes. Isoechoic means similar echogenicity to the neighboring structure. Anechoic means it's all black, that means no echoes. Hyperechoic means it's highly reflective, it looks bright in comparison to the neighboring structures. And hypoechoic is less reflective, that means it is less bright as compared to the neighboring structures. Now, these are, I'll show you different pictures, how different tissues look like under ultrasound. So these are the vessels which look absolutely anechoic, and to differentiate between vein and artery, you have to just apply pressure. Veins are compressible, arteries are not. And this is a structure, I think those who do a lot of shoulder ultrasound, they can very well identify. This is a tendon, which is a supraspinous tendon over the greater trochanter of humerus. You can see the bone, and below the bone you can see a very hypoechoic area, and there is a glistening hyperechoic line. That is the sign of a bone, and the tendon which appears fibrillar. Now, this is a typical appearance of a nerve. You can see this is basically a distal nerve, because distal nerves, they look like a honeycomb appearance. This is more hyperechoic. Distal nerves, this is actually example of the previous one, actually the example of a median nerve, which is at the level of the elbow, close to the brachial artery. You can see how hyperechoic it is. And this is again a nerve, but it looks hypoechoic. It is more proximal. This is in the interscalene group, probably root, which looks more hypoechoic in comparison to more distal nerves. Again, this is another picture of fat and muscles. Fat and muscles are basically in a hypoechoic background. You'll see hyperechoic lines, and pretty easy to identify. Again, this is another picture of bone where you get a hyperechoic rim and a hypoechoic, and below that hyperechoic rim, everything looks black. Now, I've already told you that talked about resolution. So, but there are different type of resolution you got to know. So what do you mean by resolution? This is basically ability to distinguish two structures that are close together as separate. Okay, so if two structures are present close by, then if you're able to differentiate between the two structures, that means the resolution is good. So there are different type of resolution. You can call axial resolution, lateral resolution, contrast resolution, and temporal resolution. I'll just describe quickly one by one. So axial resolution is basically when the two objects are present parallel to the ultrasound beam, and it depends upon the wavelength and also the frequency. That means in high frequency wave, because the wavelength is less, you are getting very good resolution. And in low frequency wave, because the wavelength is longer, then you are getting poor resolution. So to get good resolution, you have to use high frequency. And what is lateral resolution? Again, lateral resolution when the two structures are present perpendicular to the ultrasound beam, and it depends upon the beam width. So what do you mean by beam width? Beam width basically when the ultrasound beam is it has got three zones basically: near zone, then it converges on focal zone, then it widens out. So there is a near zone, focal zone, and far zone. To get a best resolution, you have to focus your object of interest in the focal zone. So in the focal zone, beam width is the least, and you'll get the best resolution. Now, contrast resolution, as everybody knows about the contrast, is basically to differentiate, because everything is in grayscale image. So it's the difference between different gray images, how you can better differentiate with different color of the image. That is the gray images. So there you have to adjust the brightness to visualize different structures. Now, what is temporal resolution? Temporal resolution basically is the ability to track a moving object over time, and it depends upon the frame rate. If you increase the frame rate, the temporal resolution will improve. That means you can track a moving object. But the problem is that if you increase the frame rate, your axial and the spatial resolution, that axial and lateral resolution will go down. So you have to adjust between them. Now coming to the most important part, that is how you are going to optimize an ultrasound image. That is how you are going to use different knobs of the ultrasound to get the best image possible. So there are different knobs that you can use to improve the image. There are 6 different knobs: the frequency, depth, focusing, gain, and Doppler that you can use to improve your image. Now, frequency and depth are the most commonest things that we keep on toggling to improve our image. And this is, I'm just giving an example over here how depth and frequency matters when you are doing a peripheral knob blockade. Superficial structures, as you know, you have to keep a very high frequency and you have to set a very low depth. As the depth increases, as you can see, the frequency also going down. And there is a dedicated button over in this is a M turbo sonocyte machine. There you can increase and decrease the depth. What is focusing? I've already discussed about it. You have to keep your structure in the focal zone of the ultrasound beam. And here is a very nice picture of sciatic nerve. If you keep the focus just below the object of interest, that is here the sciatic nerve, you will not get the good image. But if you keep at the focus point at the level of the nerve, you can see the picture drastically improves. And again here, you can see the focus is quite high up. So the image is not very clear. So focusing is also important. Now, what is gain? Very commonly used. Gain stands for brightness. So basically, you can improve the brightness by most of the machine, they have an auto gain machine or button also. If you press it, it automatically adjusts the brightness of the screen. So you have to have a optimal gain in the pictures to identify different structures, right? So what is TGC? TGC stands for time gain compensation. Basically, what it does, because there are different structures at different levels. So there are certain machines, there are different toggles that you can keep on adjusting to adjust the brightness at different levels. So you can have a good view of different structures present at different depths. Different machines have different knobs for it. So some of the machines, these have this five toggle switches where you can adjust it to get a good view of different structures present in different depths. Now, these are the ways how you are going to use the knob to improve image. Now, you can also manipulate your probe to improve your image. You know, probe can be manipulated on all the 3 axes, and there is a mnemonic for it. So it's called as part. Part means pressure, alignment, rotation, and tilt. So pressure, when you apply pressure, basically what you are doing is you are decreasing the depth and you are increasing the resolution here. And then alignment is moving the probe side to side so that you can align with your structure of interest to get a good view. Rotation is again clockwise, anti-clockwise movement, and tilt is again, because structures, they vary in shape and size, so you have to keep on toggling your probe to get the best image. So remember, part, pressure, alignment, rotation, and tilt. Now, apart from probe manipulation, those who are doing a lot of ultrasound guided nerve blocks, they have to manipulate the needle as well. So there are 2 approaches basically: out of plane approach and in plane approach. Out of plane approach, you know, when the needle is again perpendicular to the axis of the probe. Here you cannot see the whole length of the needle, but you'll see the tip of the needle as a bright echo. And in case of in plane approach, you can see the whole needle, where the needle is actually in plane with the probe. There are certain advantages of in plane approach because you can see the whole needle and manipulate it, and that's why it is very commonly used. But out of plane approach has its own advantages. In certain situations, you cannot use the in plane approach. There you have to use the out of plane approach, and also the needle travels a very short distance in the tissue. So it is less painful to the patient also. But the biggest drawback is that you will not get a good view of the needle. You will only see the tip of the needle. Now, because this is because you are not seeing the whole needle, sometimes it is difficult to detect the tip of the needle. So how are you going to troubleshoot it? So there are different approaches to do that. So you can look through displacement with the needle. You can do a hydrolocalization, and there is another thing we call it as dynamic needle tip position. So I will explain it in a very small video. So there you can see whenever you put the needle, you will see some tissue moving, the tenting of the tissue here. So that you can use to localize your needle. And if you can't localize that, you can inject a small volume of saline or dextrose. But thing is that don't inject local anesthetic to detect the needle position. You are going to waste it. So you can see very well how you can localize the structure. Now, what is dynamic needle tip positioning? Basically, here you have to constantly visualize the tip of the needle by adjusting the probe and moving it along with the needle. While you are moving your needle, you have to tilt your probe so that you will have a constant vision of the needle tip. Now, everybody uses in-plane approach because it is comfortable and you can see the whole length of the needle. The problem is sometimes what happens, I've seen those who are new to ultrasound guided anesthesia, they think that they have aligned the needle properly with the ultrasound, but actually they are in partial alignment. Let's see what happens actually. We'll see a short animation. You can very well appreciate what is the problem with partial alignment. Now here, as you can see, the needle is not actually properly aligned. Now see what happens. You are only seeing, you feel like this is the tip of the needle, but this is not actually the tip of the needle. You are only seeing a part of the needle, that is shaft needle. When you toggle it, you can see the whole needle coming up. And to appreciate the needle, there is a way. If you introduce the needle with the bevel off, you will see a stair-step appearance, which is very important. And very careful when you are introducing your needle, just toggle your probe to see whether you are seeing the tip or you are seeing the shaft. Otherwise, you may puncture the tissue. You are thinking that is the tip and then introduce the needle and you inadvertently puncture the vital structures. So this is very important. Now, another thing in case of, I've seen many people is that they try to introduce the needle, and suppose there is an object over here, and there are two ways you can introduce the needle. You can introduce it very close to the probe, or you can go away from the probe. Now, if you go close to the probe, let's see what picture you are getting. Now, if you go close to the probe, you can hardly see the needle. Now, if you go away from the probe, you can very well see the needle. So whenever possible, you try to introduce the needle away from the probe. So maximum part of the needle can be come under the probe and you can visualize the needle better. That is because I'll just show you an animation how it actually happens. As you can see, when the needle is parallel to the probe, most of these echoes are reflected and received by the probe. But when it is angled, most of the echoes are wasted. So whenever possible, try to introduce the needle little bit away from the probe so that you can visualize it much better. Right? Now, as you all know that, ultrasound, there is a lot of, especially ultrasound guided nerve block, there is a lot of hand-eye coordination. So ergonomics is very, very important in ultrasound. Now, there are two ways you can you do a nerve block, introduce your needle and keep your probe position. One is across, that means the operator and the needle and the probe is perpendicular to your visual axis. And here is the operator and here is your screen, and this probe and the needle are actually perpendicular. And another is along approach where everything is in line. So it is said that the along approach is the best because everything is in one line. It gives better needle beam alignment. And because here there is a problem of misalignment, partial alignment. But here there is a less chance of partial alignment because everything is in one line. It is also helpful to overcome the problems of hand dominance also. So whenever possible, try to be in the along approach rather than the across. Now, the last part that I've told you is artifacts. Artifacts are basically, I call them as ghosts, because these are the images which are present in the ultrasound, which are actually not there, but you see them. So, you have, it's very, very important that you identify these artifacts, otherwise you will be the wrong thing. Now, artifacts can be anatomic and acoustic. Anatomic artifact is called as anisotropy. Acoustic, there are many types of acoustic artifacts: shadowing, enhancement, mirroring. We'll discuss them one by one. Now, what is anisotropy? Anisotropy is basically change in the ultrasound appearance depending on the angle of insonation of the incident ultrasound. As I've told you, that this is the source, that is the probe, and this is suppose the structure, the reflector. Now, if it is parallel to each other, everything reflected back and you see the structures oval and is bright. And if it is tilted to the source, then some of these reflected waves are not being captured, so it appears dark. So that is what the theory is. Now, even if you tilt the probe according to the structures, then there will be anisotropy also, because some of the waves are wasted. Now, nerves, tendons, and muscles are notoriously anisotropic. I'll just give you an example. Those who do shoulder ultrasound, they will see that this is the bicipital groove and this is the bicipital tendon. When the probe is in line with the probe, you can very well see it. If you tilt the probe, you'll see the bicipital groove is empty. That will give you a false impression that the bicipital tendon is here or misplaced. But when you adjust it, you'll find when the probe is in line, you can very well see the bicipital tendon in the groove. So you have to be very, very careful when anisotropy before you make a diagnosis. Now, what is now coming to the acoustic artifacts? Now, what is shadowing? Shadowing is basically seen by highly reflective object or objects with very high attenuation coefficient. And it's basically what happens that because everything is observed, nothing goes below, you will see a shadow of that structure. Especially, it is here. It's a gallstone, which is a bony sort of a solid structure, and it casts a shadow because nothing goes beyond it. We commonly see it in bones, where
Dr. Bhanu, Dr.
Yes, sir.
Bhanu,
Yes,
we are
sir.
running over time. Please finish it up.
So I'll finish it up quickly. Yeah.
Okay.
Now, it is enhancement is just opposite of it, where a low attenuation object just enhances the image and everything looks bright. So this is also you have to be keep in your mind. I'll just give you an example. Here you can see the femoral nerve is actually in the lateral side, but sometimes this is the artifact, enhancement artifact. It may confuse you that this is the femoral nerve. Now, reverberation artifact is again where there are two reflective surfaces, and the ultrasound beam is basically start between the two reflective surfaces, and you will get multiple lines, parallel lines below it. And these are the typical A lines that you see in lung ultrasound. And this is also you see when you use needle. This is called as reverberation artifact because needle has two surfaces and they are widely reflective. So you will see multiple of needles below it. Another is mirroring artifact. This happens when there is a highly reflective material below an object, which actually creates a reflective image. This structure is actually not present here, but actually a mirror image of it. So this is seen in case of lung ultrasound, where liver is reflected just below the diaphragm. So you call it as hepatization of lung, which is seen in case of pneumonia, but actually it is the reflection of mirror. So you have to toggle your probe to remove this artifact. This is called a speed artifact when the ultrasound wave passes through different tissues, and it is commonly seen in case of needle where the needle appears bent. Actually, the needle is not bent. It happens because of the velocity artifact or speed artifact. So this is all about artifacts, and I think ultrasound something I think everyone should start doing because it is something that gives you so much of advantage. But there is a steep learning curve. The best thing is that you keep scanning and keep learning, and there you can master this machine. So I'll finish up my lecture with this beautiful quote from John Maxwell: "The more you do, the more you fail. The more you fail, the more you learn. The more you learn, the better you get." Thank you.
Thank you, Dr. Bhanu. It was very well presented. You covered all the aspect of basics of ultrasound. And this is not only important, rather I would say it is an essential part for everyone to learn this before going for ultrasound. Without wasting much time, because we will keep question answers in the last, I will call Dr. Hrishikesh Jha from Ranchi, and his interest in point of care ultrasound. So I would call upon Dr. Hrishikesh Jha, and I would request that if he is presenting from laptop, should be close to your microphone, or if you are using the earphones, then nothing like that, because otherwise sound often is, we are losing the sound quality, and we are unable to understand that what the speaker is saying. Yeah, Hrishikesh.
Sir, good evening.
Yeah. You can start your slides.
Just a second, sir. Is this visible?
Yeah, it's visible, Hrishikesh.
Okay, I need to start.
Is it the first slide? I don't
No,
think
sir,
so.
this is the last. Just a second. I'll just get through to the first slide. Yes, sir. Yeah.
Yeah, you can start, please.
So after a brilliant first talk, I'll be talking about POCUS. POCUS has been with us for a pretty long time now with the anesthesiologist, and it has grown by leaps and bounds over the years. I am here only to talk on one aspect of it, and that is seeking for the harmony between blue and red. As you can see, this is from the University of Nottingham. They have divided POCUS uses to everything like possible airways, breathing, circulation, disability, and everything else. So out of these, it was impossible to cover all the topics within a span of 20 minutes, to which I'll try to stick to. I'll be only talking about one aspect of POCUS, and that is about IVC and fluids. Because as I said, it's all about the red and the blue harmony that I care for the most in my patients. Whenever we are confronted with a patient in the ICU, or even say a general ward, where we don't get much clue out of what kind of patient we are facing, the first reaction that we generally have is to give the patient fluids. If you have a documented negative fluid balance, you give fluids, all right. But if you've got a urine sodium less than 20, still give fluids. If you got hypertension, still fluids. AKI, go for fluids. Elevated lactate, go for fluids. Lung sounds clear? Okay. We don't need to do anything, go for fluids. And basically what we do is land the patient up into something that is really bad for him, that is congestion. Congestion is just as bad as a dry patient. A dry patient and an ocean of a patient, both are bad. So it's very well documented by Dr. Bjsa, where he says that the risk of complication is equal for both hypovolemia and hypervolemia. In hypovolemia, you may have altered tissue perfusion, renal failure, anastomotic leakages, confusion, risk of CVA, splanchnic ischemia, and finally multi-organ failure. Ditto for hypervolemic state, where you get edema, intra-abdominal hypertension, respiratory failure, impaired healing, altered mentation, and landing up in multi-organ failure towards the end. So initially, whenever we were confronted with such questions, we always had something in our arsenal which we ascribed to as fluid responsiveness. We were only driven into giving fluid to our patients, simply dependent upon a few ultrasound findings, especially the LVOT VTI, that is the velocity time integral variation with regards to respiration when on mechanical ventilation or by passive leg raising. However, we've come to realize that the more critical part is to know when to stop resuscitation and when the patient is actually harmed by my fluid, by my giving him fluids. So though resus, basically it aims to preserve the tissue perfusion, we need to remember that the tissue perfusion is not only about MAP minus CVP, because as we know that in the states of sepsis, the mean arterial pressure drops, it does drop, and because of the extra fluid that we give to our patients, the venous pressure rises. At the microcirculatory level, where there is a microcirculatory and macrocirculatory disjunction, you'll see that it's further compounded by a rising interstitial pressure because the tissue pressures, they rise as well. And the pressure difference between the terminal meta-arterioles and the arterioles and the post-capillary venules, that pressure difference is lost. And this causes something called as the creation of critical closing pressure, and further exchange of nutrients across the capillary is not even possible. This is the vascular bottleneck that I was talking of. This is the vascular bottleneck of the vascular cascade, wherein you can see that in the LV, the pressures are really high. I mean, this is for a normal state. 120, that is what is expected, with the LV pressures, diastolic pressures reaching near zero. And the arterial pressure is at 120 upon 80. And then you've got a peripheral augmentation of the pressures. And gradually, as you come down the lower caliber arteries, the smaller arteries, and then onto the arterioles and capillaries, the pressure keeps on dropping. Now, in the state where we have got a venous congestion, these vena cava pressures, they come up, they rise. The venous pressure rises, the capillary pressure, it dips further. So there is an inversion of this curve that you see here towards this way. So there is a state wherein there is absolutely no exchange occurring at the tissue level. We have always been only led by the left heart pressures for fluid resuscitation. Fluid tolerance of the left side, the endpoints of which have been an extravascular lung water index of 3 to 7 ml per kg, with normal A lines signifying that yes, this is a stage where you can keep giving fluids. And once this extra lung water index, it exceeds 10 milliliters per kg on transpulmonary thermodilution with appearance of bilateral beam morphology, then we say that is the end of it. But we have been ignoring the right side of the heart for all this while. Fluid tolerance for the right side so far has been only been dependent upon the central venous pressure and the vena cava respirophasic variation, which are further confounded by the mechanical ventilation and high PEEP. So right-sided congestion is something which has been pretty much ignored for so long. For the past 2 years or so, we have come up with a score called as VEXUS, wherein we see venous excess upon ultrasound. The right-sided congestion is because either of fluid overload, which we normally do, I mean, as anesthesiologists as well. It could be because of RV failure, because of an infective state or RVMI, and chronic untreated pulmonary hypertension, as is in the case of a lot of patients with COPD that you find, they have cor pulmonale. The right side of the heart is generally having features because of chronic pulmonary hypertension. These lead to an increase in CVP. This increase in the central venous pressure can be manifested by the way of cerebrovenous congestion as cardiocerebral syndrome, or by renal venous congestion leading to cardiorenal syndrome. And then this this kidney, being a capsulated structure, is very likely to go for tamponade effect. And at the same time, it doesn't spare the intestines as well. And it leads to further translocation, bacterial translocation, endotoxemia, and a cytokine storm, leading to SIRS and finally as multi-organ failure. So what do we do? Now I'll show you this heart. Now you see this heart has got a different contraction method for the right side and a different one for the left. The right heart is actually a longitudinally contracting chamber, whereas the left ventricle is a circularly contracting chamber. So this longitudinal contraction of the heart, what it does is that during the systole of the right side of the heart, this chamber, it gets more roomy. It's got more room. So once there is more room, what happens is the blood from the downstream structure, they come into the right atrium. So if I just put this into a pictorial form, this is what you get. This is the A wave. And now as the systole comes in, what happens is blood is drawn from all the structures which are downstream. And this is represented on Doppler by a deep S wave or a systolic wave. And similarly, we've got a diastolic wave in the later phase when there is the appearance of the Y descent. So for all the fluid that is administered to any patient, whether it is a physiological patient or a pathological patient, the Fluid Academy, it recommends something to be done on a later at a later date or time, because fluid, after all, is equivalent to a drug. So whenever you are resuscitating a patient, you resuscitate, follow it by an optimization, then stabilization, and finally you've got to evacuate. So the U rose is basically a rose which is guided by ultrasound. And this is aided since the appearance of Vexus. In Vexus, what we do is basically that we look at the structures which are downstream from the right side, that is the liver, and we actually get a Doppler of the hepatic veins done. The gut, the insonation for portal vein is done basically to look at how good or bad your gut is, and the kidneys are insonated for through their renal veins. It is to be remembered that the cardinal point or the set out point for determination of Vexus lies with an IVC. The prerequisite for conducting the Vexus is that your IVC should be at least 2 centimeters in diameter, maximal diameter. You've always got to figure out that whether you are taking the diameter at its maximal point or there is a cylinder effect where you are taking it at a periphery. So you've always got to take it at the central point. Am I audible?
Yes, Dr. Rishi, you are audible. Please continue.
Excellent. So the thing to be remembered other than that is that you see the IVC here. The IVC, if you can see it here, it's got 2 axes. There's a lateromedial or mediolateral axis and an anterior-posterior axis. It has to be remembered that the IVC always collapses in the anteroposterior plane and not in the transverse or the coronal plane. So whenever you've got to start with your IVC evaluation, it has got to be from the sub-xiphoid or the epigastric insonation and not from the coronal plane. In the coronal plane, if you see, what happens is for this very patient, you'll see that the coronal plane, it does not show collapse of any kind. So this has to be always remembered, that you are insonating it from the right recommended view. The second thing that you need to remember is that the aorta lies very close to the IVC. Now you see this is more than 2 centimeters and it is non-collapsing. So you've got to remember that the IVC is generally marked by the presence of a hepatic vein which is draining into the IVC, and this you will never find with the aorta. So whenever you are in a fix, either you can go for a pulse rate Doppler, or you can just look for this landmark. Now, in this picture, you can see that the IVC is dilated, non-collapsing, and the hepatic veins are dilated as well. And this represents the bunny sign. The same thing, if you see in the longitudinal axis, you will see a dilated, non-collapsing IVC. You can appreciate that there is no collapse at all. Just see, there's no collapse. So after this, what we do is that we go to the hepatic veins. As I showed you earlier, that the runoff to the right atrium causes a deep S wave, and the diastolic wave follows it later. If you see this carefully, this replicates the CVP waveform pattern. So in a normal patient, this is what you would expect. As the right atrial pressure rises, there is more difficulty for drainage of the hepatic vein into the right atrium. So the S wave will progressively become smaller and smaller. This is small. So much so that at one point in time, the systolic wave starts appearing above the baseline. This is also called as AS wave, followed by the D wave. So if you have got a S wave, which is smaller than D wave, you call it as mild. You've graded it at mild. If there is alternating, like here you can see there's appearance here, when there's an alternating S wave, and which is much lesser than the size of the D wave, or if it goes above the line occasionally, we call that as moderate. And if it is altered completely, so that the S wave now is above the line and the D wave is only below the line, we call it as severe hepatic congestion. The next thing that we look at is the portal vein. The portal vein, you will see, is reflective of the gut. The portal vein has got a continuous linear, near continuous linear laminar flow, you would say. And this laminar flow can sometimes be up a little pulsatile, but not very pulsatile. It's never more than 30%, and that to be found in obese individuals is very rare. You can maximally find it in young, thin patients. And how do you calculate the pulsatility? The pulsatility is always calculated by the maximum velocity minus the minimum velocity divided by the maximum velocity times 100. That is what we do to calculate the pulsatility. Now you see, as the right atrial pressure increases, the pulsatility goes up further and further. Here it is somewhere between 30 to 50%. As the right atrial pressure rises further, the pulsatility goes definitely beyond 50%. And you can see occasionally the waves are also going in an opposite direction. And the flow reversal can finally progress onto to and fro pattern. And this sometimes are so difficult to make out from the SD pattern that the hepatic veins develop. So this is to be again graded. This is mild, this is moderate, and this is severe. Finally, we look at the intrarenal venous Dopplers. The intrarenal venous Dopplers are difficult to get in isolation because in the kidneys, the artery and the vein, they lie very close to each other. And whenever you try to insunate one, you always tend to get the other as well. So when we try to trace it, we get an arterial wave above and a venous wave below. The venous wave, as you can see, is again continuous, much like the portal vein that we find. However, as the right atrial pressure increases, you will see this laminar flow, it goes into a pulsatile flow. Initially, the whole of the systole and diastole is covered by two different waves. One is a distinct S wave and a D wave. And as the right atrial pressure goes up further, what happens is that the systolic wave is lost and only the diastolic wave remains. So this again requires a grading. So this is mild, this is moderate, and this is severe. Now, summing it all up, let's see what does this mean. These, as I said, we basically insonate the hepatic wave, the IVC, check whether its dimensions are adequate enough to go for further examination, that is for the hepatic vein, portal vein, and renal vein. If not, we do not continue with the Vexus examination any further. The normal waves, as I said, this is for the hepatic veins, where the S is more than D. This is the portal vein, where there is a pulsatility but less than 30%. And this is the renal vein, where you've got a laminar continuous waveform in the renal vein. For a mildly abnormal one, what we get is a S wave, which is smaller than a D wave in the hepatic vein, and S wave reversal with a tall D wave is it signifies severely abnormal hepatic flow. Portal vein shows a mildly abnormal when the hepatic vein pulsatility is anywhere between 30 and 50%, and severely abnormal when it is more than 50%. Renal venous Doppler will show S and D, two distinct waves. This is biphasic, and then turning on to become monophasic, only there will be a diastolic flow in the renal veins. This signifies severely abnormal state. So you can grade it further as grade 1, grade 2, or grade 3 on Vexus. In grade 1 Vexus, what we get is just mild congestion. Grade 2 is it signifies moderate congestion, and grade 3 it denotes severe congestion. For grade 3, what you require is an IVC diameter of more than 2 with more than 2 severely abnormal patterns, either this and this, or this and this, or this and this. So either ways. Grade 2 is when your IVC diameter is more than 2 centimeter and one severely abnormal pattern. You don't require a mildly abnormal one, just one severe abnormal, and an IVC which is dilated signifies grade 2. And grade 1 can have any combo of normal or mildly abnormal patterns. So I use this pretty often, and it's very gratifying. Like I'm showing you one example. This is of a few months back. 24th, the patient presents with SD pattern. This you can see is 100% pulsatile, and there is monophasic renal vein. Here the SD pattern, this persists. This also is persistent, but the phasicity has allowed for a greater venous drainage. Gradually, you see what happens is that the hepatic vein form changes further, and towards 29th, between 24th and 29th, just look at how the pulsatility has changed. And this could be achieved just by mere diuresis. The patient had an ejection fraction of close to 20%. His creatinine was 4. His liver enzymes were all over the place. But what we actually chose for was decongestion. And by the 30th, the patient was ambulatory. Thank you very much.
Yeah, Rishikesh, this was really an eye-opener. Beautifully presented, very, very simplified, and it was just a master skill you have shown. And really, hats off to you. You presented very beautifully. Now, I would call upon Dr. Sahu if he has joined.
Sir, Ashok sir, this is Dr. Jayaprakash. I would like to, hello,
Yeah,
Can
yeah,
I-
yeah.
can I tell few
Yes,
things?
yes, yes.
Because
Yeah.
only the issue on IVC, it was saying that, but I would like to add few things that left LVO2 if you have to, because the beauty of focus is that every time the patient condition is changing in ICU. So if we are seeing only IVC, we should also see about LVO2, that how much fluid is required. This is not mean that the patient when require we are giving less fluid just after 5 hours, patient may not, we should not give the fluid. That is totally depend on the every patient is not similar.
I agree with you, Dr. Jayaprakash, but what he tried to focus is particularly on the IVC and then hepatic veins and the combo with the renal veins. What you are saying is also very much appreciated. And of course, this will be an add-on and will guide further. So now I can call, Dr. Sahu, take over and please introduce the next speaker.
Thank you, Dr. Zadan. Good evening, all of you. Thanks, Sarad sir, the team, BJ, Anesthesia, Bihar Jharkhand Society of Anesthesia. It is a great honor to be here. It was wonderful listening to the two lectures, Dr. Swami and Dr. Jha. It was fantastic. And without any further delay, let me introduce the next speaker, one of my friend, Dr. Chandini Sinha. She is additional professor at AIIMS Patna. She has more than 100 papers to her credit, both national and international. She has authored few book chapters as well. Recently, all of you must have seen her post. She was awarded third paper in the e-post category at the ESA in Greece. She also had got Best Paper Award in the Dublin ESRA Workshop 2019. Her interests include regional anesthesia, pediatric anesthesia, and she has been a fantastic organizer of few meetings, ultrasound meetings at AIIMS and few other meetings as well. So we are eagerly waiting forward to her lecture on recent advances in regional anesthesia. Over to you, Dr. Sinha.
Thank you, sir. Is the screen visible?
Oh, yes, it is visible, yes.
Okay. So in the beginning, a very good evening to all of you. And I would like to thank Dr. Sharad for asking me to bring this lecture. Thank you for the opportunity, sir. And it is always a humbling experience. It is always my pleasure to speak in front of Jadon sir, who are renowned personalities in regional anesthesia. So it is my honor to speak in front of them. And I would be speaking about advances in regional anesthesia. So before I go to the advances, let's talk a bit about the history. How did regional anesthesia come into being? So it has come a long way. First nerve block, that was a block with cocaine. So, William Hamster, as we know, is famous for his surgeon to administer nerve block, that is the inferior alveolar nerve, with ionization of the subarachnoid space. And this was done by Mr. Bayer, who actually gave us IVRA also later. So as we see over the next few years, the advances were mostly limited to epidural as well as development of new drugs. And finally, it was in 1989 that ultrasound was used for visualization of local anesthetic spread. Okay. So why has the growth of why so much of growth of regional anesthesia over the few years? So there's been better understanding of the anatomy, pharmacology, and regional anesthesia was initially dreaded because of the toxicity it could cause. But over a period of time, its antidote was developed, that is intralipid. There's ultrasound revolution over the period of time with the presence of ultrasound in many of our operation theaters. And also, there was an increased demand of daycare surgeries. Then, as days progress, there's increased longevity of patients. So we have more of geriatric patients with a significant burden of cardiorespiratory and metabolic diseases, in which regional anesthesia comes handy. So it is not merely an alternative to general anesthesia, rather it complements an overall multimodal anesthetic strategy. So the advances basically are targeted not only to provide a pain-free patient, but also to improve the quality of pain relief. As in, you won't want a patient who's completely pain-free, but is not able to mobilize or might be has a phrenic nerve palsy. So the advancements were to provide a safe analgesia to the patient. It was I've just mainly categorized into advancements to increase the duration of block, to prevent complications, that is the intraneural block, and increase patient comfort, as well as the newer blocks which have come, and the training related to regional anesthesia. So talking about the duration, one of the biggest limitation of regional anesthesia is that it has a finite duration of single injection technique. You know, you might be having a pain-free period for a period of pain-free patient for a period of 6 hours, but after that, what happens? He might have a rebound post-surgical pain, which might be in fact more difficult to manage. So in these cases, you can actually end up using adjuvants. A lot has been said about liposomal bupivacaine as well as catheter technique. I would be dealing them one by one. So talking about adjuvants, as we see, the most commonly used adjuvant is adrenaline. So adrenaline is tachycardia and hypertension. But what is good about adrenaline is that it is not only safe, it is safe, but it is also approved by the FDA. Talking
Dr.
about
Chandni,
clonidine,
sir,
many of us, yeah,
yeah, sorry to
yeah.
interrupt. There's a bit of breakage in your voice. Can I just request you to switch off your video? Sometimes that improves the voice also. Maybe
Yeah. Actually, the
maybe
internet is
that.
quite unstable. I'm still at the hospital. Yeah.
Okay. Switching off
Okay.
the video might
So
help sometimes. No, yeah. Let's try
yeah,
that.
yeah. Okay. So we're talking about adjuvants. So talking about alpha 2 agonists. So we have clonidine as well as dexmedetomidine. So clonidine, as we can see, in vitro toxicity, it is unsafe. And dexmedetomidine, though it is safe, both of these are not FDA approved. So coming to dexamethasone, which can be used IV or perineurally. It has acceptable safety profile, and it has one of the longest prolongations of analgesia. So what is recommended now is dexamethasone, but as I said, studies have shown that there is not much of benefit giving it perineurally. So in fact, IV route might be preferred. It has a ceiling dose of 4 milligram. Talking about liposomal bupivacaine, so what are liposomes? So liposomes are microscopic structures which consist of phospholipid bilayer with the aqueous core. So it was marketed by Pakira Pharmaceuticals, San Diego, California. So it basically consists of, as I said, it has a phospholipid bilayer with bupivacaine vesicles in the center. But the issue with liposomal bupivacaine is that FDA has approved it only for surgical infiltration, for interscalene block, and for TAP blocks. Studies have shown decreased pain scores in TKR after a femoral nerve block, but again, this is not FDA approved. The problem with liposomal bupivacaine is its availability, and it is around 200 times as expensive as plain bupivacaine. So then came the catheter over needle technique, that is use of continuous catheters. So the use of the most commonly used technique was catheter over needle technique, wherein a needle was inserted, and so it was a cannula which was left in situ, followed by the insertion of e-catheter inside the cannula. So, but the problem with catheter over use of continuous catheters was that it was more complex to perform. It is more expensive. Also, it requires post-operative monitoring because you wouldn't want a patient to have prolonged conduction blockage or might have patients complaining of tingling later on. Also, there is a high risk, or there's a risk of secondary failure rate. Again, these are not suited for daycare surgery. So though they came in a big way, catheters are not usually used now. So as I said, so among all of these, the use of local anesthetic adjuncts, mostly dexamethasone, is done very usually and is handy. So now talking about a bit deviating from the topic, the use of PCA pumps. Okay, so PCA pump for labor analgesia, a newer concept which has actually come lately, is that program intermittent epidural bolus along with patient controlled epidural analgesia provides a better regime than a continuous epidural infusion along with patient control. Earlier, we used to start the patient on continuous epidural infusion, but lately they have found that program intermittent epidural bolus, there's more patient satisfaction as well as lesser usage of local anesthetic. So now talking about prevention of intraneural injections. I would like to describe the anatomy of the nerve initially. So as what we can see, you have the axon, which is surrounded by the endoneurium. And multiple of these axons, they form the fascicle, which is surrounded by the perineurium. And multiple fascicles eventually get surrounded by the epineurium, the outer layer of epineurium. So whenever you're giving a block, so the areas where you can actually end up giving a block is you could go intrafascicular, you could go extrafascicular, or you could go subparaneural. But when you look using the ultrasound, do you actually make out where you're going? Can I actually make out, looking at this figure in the supraclavicular block, that where I'm going, whether it's intrafascicular or extrafascicular? It is actually very difficult to make out. So in a case series which was done in interscaling block, what they observed that 200 blocks which were given using ultrasound, around 6 of them had intraneural injection because they presented with symptoms later on. Now, so there came a concept of triple monitoring, as in use of ultrasound along with PNS, along with uh, pressure monitoring. So pressure monitoring, there are two devices which are available right now. One is B-Smart and the other one is Nerve Guard. So this B-Smart is marketed by B-Braun. So what these pressure monitoring basically do is that they monitor the pressure, the injection opening pressure, and the experimental models. That is, on porcine models, it has been shown when the pressure exceeds more than 15 psig, the chances of intraneural injection is very high. So this B-Smart has to be attached to the syringe through which you're giving the drug. So pressure more than 15 is usually represented by yellow or the orange color. So you come to know when you have to stop the injection. So Nerve Guard, which is marketed by Peon, is in fact a bit better, as in you just attach it to the circuit, and then what happens if the pressure is more than 15 psig, the injection automatically stops. It cuts off the injection. An extension to this is Sapphire technique, that is safe injection for regional anesthesia. So as we can see here, the needle is attached to a syringe, the syringe is attached to the pump kind of thing, and then there is this foot pedal. So as I'm giving the block, I operate the foot pedal myself. So when I know that okay, I'm near the plexus, I press onto the foot pedal, and the drug gets delivered through the syringe and the needle. See, the advantage here is that, again, it has a built-in safety mechanism that limits injection pressure to less than 15 psig by automatically stopping. Also, that I don't need an assistant. I would be giving the local anesthetic myself. I have full control of the injection. So innovation in this field, there is there's this new device in which the pressure monitoring is at the tip of the needle itself. So it consists of an optical fiber basically at the end, which has an optical cavity, and it tends to measure the pressures. Again, another difficulty which lots of people face is the visualization of the needle. So many a times the shaft is visible, but the tip is not. And many a times when you visualize the tip, the shaft might not be visible. So a new tip tracking needle has been developed by the Philips. So what they have done, they have put a piezo element into the needle shaft, which is near at the tip of the needle shaft. The signal is processed and it is represented on the ultrasound screen as a green signal. So this is the piezo element which I was talking about, which is near the tip of the needle. And as the needle advances, the tip can be visualized as the green circle. So there have been multiple studies which have actually said that this new needle tip tracking is beneficial, as in it reduces the procedure time and number of hand movements, especially for out of plane procedure. There was no significant difference which was found for in plane procedure. So, but what we really need to remember that these studies have all been done in cadaveric models or animal models. So the next thing which could have been done is the use of micro ultrasound. So what has happened? So as we know that as we increase the frequency of the ultrasound, though the resolution becomes better, we can't visualize the deeper structure. So what has been done? We have taken the ultrasound probe as close to the target, as in the needle has one incorporated ultrasound in it, and the ultrasound has a high frequency, it has a frequency of more than 30 hertz and resolution of 40 to 100 microgram, which makes the visualization much better. So as we can see, the needle is approaching and look at the nerve. In fact, we can actually make out the fascicles also. This is because of use of micro ultrasound. Again, all of this has been used in animal models. Talking about patient comfort, the use of virtual reality has come in a big way in the West. There was this big study which was done in which half of the patients received upper limb blocks after upper limb blocks, and while giving the block, they were in a different environment because of virtual reality. And what was noticed that these patients had better post-operative satisfaction score and better hemodynamics during the procedure. So I couldn't get a picture of virtual reality for this peripheral regional anesthesia, but virtual reality is also used for venipuncture in pediatric patients. So we can see in this patient. So talking about neoblocks, the concept of neoblocks is again, as in not only providing pain release, but also reducing the adverse effects. Hence, interfacial plane blocks have become very important because especially in thoracic and abdominal areas, because the problem with epidural or paravertebral was that it was very close to the neuraxis, the high chances of pleural puncture or spinal cord injury. So one of the block which I think everybody does and everybody loves is erector spinae block. So again, the visualization is quite easy, wherein you visualize the paraspinal muscles over the transverse process and give the drug over the transverse process. Though it is quite safe, but various meta-analysis and systematic reviews have said that it might reduce the analgesic requirement, but whether it is clinically important or not is quite questionable. As a result of which, it has still not been incorporated in various guidelines. For example, Prospect still does not talk about erector spinae, saying that they need more studies. Talking about IPAC block, that is IPAC stands for infiltration between popliteal artery and the knee capsule. Again, a very important block which was advocated, which was initially described by Dr. Sanjay Sinha, an Indian in UK, who would actually mobilize the patients of PKR in the evening itself by giving an adductor canal block along with an IPAC block. The advantage again remains the same, that is compared to a sciatic nerve block, it does not cause motor blocking. So the visualization is quite easy. So wherein you keep the probe above the medial tubercle, and what you see is the popliteal artery, the way the needle comes something like this between the femur and the vessels, and you deposit around 15 ml of local anesthetic. So again, systematic reviews haven't established the role of IPAC, saying that currently there is limited evidence supporting the use of IPAC, but might be over a period of time, as we have more studies, this could really be helpful. Initially, interscalene blocks were the gold standard for shoulder analgesia, shoulder surgeries, because they provided excellent analgesia. But the most common problem with interscalene block is the phrenic nerve palsy, as in whether you want it, don't want it, it was there. So this paper, again a landmark study, wherein it was a cadaveric study, wherein they showed that instead of blocking it at the C5, C6 root level, what would be done is like C5 and C6, the point where they form the C5, C6 roots, where they form the trunk. And then again, they divide into two divisions, the anterior division and the posterior division. It could be given, the block could be given there. So as you can notice, this is the trunk, and what we can notice, the phrenic nerve actually has moved away. So the phrenic nerve has moved away, and so the chances of local anesthetic going and spilling here is quite less. And good thing is that we also have the suprascapular nerve coming from here. So the analgesic efficacy of this block has been established, and in various studies for shoulder arthroscopies as well as for shoulder open surgeries. And studies have shown that the diaphragmatic movement is not much affected. Talking about another block, which is a favorite of mine, is the costoclavicular block. So the costoclavicular costoclavicular space is a space which is actually just below the clavicle, below the pectoralis major and the subclavius. So what we notice here is that all the three cords of the infraclavicular, three cords of the brachial plexus, they lie lateral to the axillary artery, and the position is quite superficial. So when we place a probe somewhere here, so what we notice here is axillary artery and lateral to it, all the three cords are clustered. So obviously this block is easier to do because you don't require you don't have to see the U shape. You need not be that worried about the spread of the local anesthetic, and the requirement of local anesthetic would be lesser than classical parasagittal approach. So the other blocks which are present but I'm not covering also includes various interfacial blocks like PEG block, SAP block, PENG block, that is pericapsular nerve block, or hip surgeries, QL block. Now talking about the use of simulation for training. So the problem with regional anesthesia is that as the majority of these nerve blocks or plexus blocks, they are quite close to vessels or organs of pleura. So it is not easy, it is quite difficult, and it has a steep learning curve. So the advantage of simulation is that it avoids the potential harm to the patients, and then you can do it repeatedly and feedback can be given by a third person. So in fact, it has become a recommended modality for residency program. So this study in which they had a second year residency students who had not been exposed to regional anesthesia at all, they were divided into two groups. The first group received the conventional training, that is the didactic lectures, while the second group, apart from the didactic lectures on regional anesthesia, they underwent simulation-based training. And what was noticed when they actually went to perform the blocks, the percentage of successful nerve blocks was higher in students who had undergone simulation training. So again, there have been studies wherein robots have been also used for nerve blocks, needle guidance. So this was something like this, wherein wherein there were two arms of the robot. One of the arm stabilized the ultrasound probe, and the other was used for needle insertion. Talking about artificial intelligence in nerves, so it could in regional anesthesia, it could be used for tracking of nerves. But again, it is very difficult in few of our nerves in our body because these nerves tend to constantly change its appearance. For example, sciatic, it could be compressed or it could be round oval at the various level it passes. So analysis of image could be a slow, inefficient, intensive process. But again, using AI for a nerve like median nerve has been successful. So these were the works which were done till now, but the next frontier, as in the next things which we need to work upon, though regional anesthesia availability, as in ultrasound availability is there, its acceptance rate is less, as in with the surgeons, with the patients. So there is much more requirement of awareness. Also, there's underutilization of regional anesthesia in pediatric patients, despite there's so many studies saying that general anesthesia leads to neurodevelopmental delay. Also, it should be simulation. Also, if this simulation-based training, at least in our setup, is still not there. Hence, to conclude that the role of regional anesthesia in perioperative care is more important than it was ever before. Also, that with the use of adjuncts, the clinical duration of local anesthetic is increased a lot. Development of facial plane blocks has made our life easy. It's very easy to learn. And there should be a continued investment into regional anesthesia education and also the recognition of limitations. Thank you. This is my team of AIMS Patna. I think Dr. Nishant is missing. He was somewhere else. A big thank you to all of you.
Wonderful presentation, Dr. Sinha. So it was really refreshing to listen to you, and you rightly highlighted few things about most importantly safety part. Use of ultrasound doesn't guarantee that you're not going to do any intraneural injection or kind of prevent it, but you highlighted about availability of newer gadgets, the pressure monitoring, the other things. But the only difficulty is that wider availability in our country, and also the cost associated with the newer things. So that is one thing we hope in future that will be widely available, and also the cost will be reduced, specifically in the teaching institutes or apex institute like yours in AIMS and subsequent places. Well, you talked about the adjuvants, the other things also. It was really good to listen to you, and thank you very much for that. I think we're open for questions. If there is anything anybody wants to ask, and if there is anything in the chat box, we can probably ask those to the speakers and get back their expert opinions. Anything over there? Questions? Anything, sir?
Hello. Hello, can I ask question to Bhanu?
Yes, sir. Yes, sir. Please go ahead.
Dr. Bhanu, myself,
Yes, sir.
Dr. Manoj Kumar.
Yes, sir. Yes, sir. You can ask a question.
How can I increase the acoustic impedance of ultrasound transducer to promote cavitation?
Can you repeat your question, sir?
How can I increase the acoustic impedance of ultrasonic transducer to promote cavitation?
I didn't get you. You promote cavitation.
Yeah. 1 second. I repeat 1 second.
Your voice is
How
actually
can
breaking
I
up.
increase the acoustic impedance of
Acoustic
ultrasonic transducer to
Okay.
promote cavitation?
Your last word is what? Cavitation.
How can I increase acoustic impedance? Yeah.
So what
To promote cavitation.
Acoustic impedance is the property of the
Impedance.
structure.
Yeah.
You cannot change that.
See, it is the property of a tissue. You cannot change the impedance of a thing. Only thing is that if there is air in between your probe and this thing, then you can use a lot of jellies and stuff to, decrease the barrier. You can remove the air because air is the biggest reflector of ultrasound. You cannot visualize anything beyond it. So that you can do. Truly speaking, I didn't understand your question, but what I
Can I repeat once again?
yeah.
How can I increase the acoustic impedance of ultrasonic transducer to promote cavitation?
To promote,
Cavitation.
we cannot do.
Cavitation is the breakdown of the fat tissue under the skin.
Crepitation.
Cavitation.
Pressure, you just give more pressure, but that will decrease the impedance. You cannot increase the impedance. Increasing impedance will only cause poorer ultrasound images.
Can I use two transducer to promote cavitation?
Two transducers actually are used sometimes, but they actually, the ultrasound beams, they collide with each other and they give a much poorer image, both of them.
Or different value of the acoustic impedance to different tissue. I think air is less acoustic impedance value
Because
than bone.
this has been tried on a few, especially patients with transcranial Doppler. They do something called as stereotactic ultrasound therapy. So there they use two different probes and they direct it to a certain point for more of thrombolysis. But I don't know if it is used in any other purpose.
Okay, thank you. Any sir, review by Dr. Jadon, sir?
Yeah, Dr. Manoj, good evening.
Good evening, sir.
What you said, what he has already explained, this is the place intracranially when they want to do, they use it. And for the routine anesthesia practice, actually, it is not of much help. We do not read all these things. But yes, when there is intracranial interventions, then they do it. What you are saying is right.
So can we use double transducer?
In routine practice, we usually do not use because they will interfere with each other's perception and the echoing and can confuse. They will create a sort of confusing image until unless the technology is there which can amalgamate the inputs from both the probes and also resolve and read them. Because what was happening in the beginning, there was a one crystal. So then there came the multi-crystal technology. So what you are trying to say may be possible in the future, but not at present in the routine practice.
Sir, how
Dr.
can
Sahu,
sir, how can
Dr. Sahu
calculate?
can take his inputs. Yeah, what are you saying? Yeah, repeat, Dr. Manoj.
Sir, what is the formula of acoustic impedance? How can calculate acoustic impedance for different tissue? This is actually
Dr. Manoj, I have already put it in my lecture. Acoustic impedance depend upon two things. It is the density of the tissue and the velocity. You can multiply the density and velocity and you can calculate the acoustic impedance.
I think it answered you. Yeah.
Dr. Sahu.
Okay, I totally agree with what other speakers have previously told. The acoustic impedance is something we have very less control of. But that is basically the tissue interaction, how the ultrasound echo goes, what kind of structure it hits, and what is the resistance that tissue is providing, say air or bone, blood vessel, or whatever it is, So you have not much of control over that, maybe like in future technology that will say in future, but as of now, I've never used two ultrasound probes together. Things will be distorted, things will be very confusing. So yeah, so it has already been explained by Dr. Jordan and others.
Okay, thank you. Thank you all, speaker
Welcome.
and Sahu sir and Jordan sir, our chief guest, Dr. Sabyasachi Das, and our smart and dynamic president, Dr. DK Singh sir, and dynamic secretary, Dr. Sarath Boss. Thank you.
Yeah, I would like to give one or two inputs. Dr. Chandni is there.
Sir.
Dr. Chandni, you were the brilliant best as always. Nothing to add. You are one of the best speaker I ever heard. Only thing I just want to give little input. You have covered 99.99%. Two things, maybe directly or indirectly related to recent advances. It is in perspective of practice, change in practice. One is that now a lot of regional are coming in the ERAS protocol, as you must be aware about it.
Yes, sir.
And one more thing, now we are going to the non-specific, to the algorithm-based specific blocks to a particular block, particular surgery. These two things are coming in a very big way, and possibly after some time guidelines will come. It is not like that you want to operate for hand and somebody is giving supraclavicular and somebody is giving axillary, nothing like that. They have to be specific indications and protocol-based practices, and that will naturally give some homogeneity in everybody's practice, and of course affecting the outcome. Otherwise, your presentation was perfect, to the point, and covered almost all the aspects.
Thank you, sir. I always welcome your input, sir. Always.
Thank you. Dr. Sharad?
Yes, sir.
Yeah, you can take over, and now I think any question, any further question,
Okay,
somebody is asking.
Okay.
About one line, I would like to say something about Dr. Rishikesh also. And he presented excellent. Of course, there were few suggestions like to include LV function as well as the other parameters also. So including that, what I have suggested to the other listener, that his focus was all these three parameters. And if you have time, if you have expertise, you can include the rest of the parameters to enhance the capturing power of your ultrasound also. That much I can say. Now it is, you can take over, Dr. Sharad. It is over to you.
Thank you very much, sir.
Sharad sir, can I just say something?
Yeah, please do that. Please go ahead.
So because for my previous speakers, actually, so when I got this topic, so I was quite happy because obviously it's my area of interest. And secondly, I was happy I did not get the first topic, because I personally find that it is a dry topic, but a very difficult topic to explain to the audience, which I think Dr. Bhanu Pratap did wonderfully with all the illustrations and the videos which he had. And so a big congratulations to you, Dr. Bhanu. And for Dr. Rishikesh, you wonderfully explained. Even a person like me who's not into critical care actually understood. It's a big achievement. Congratulations to both of you.
Thank you, madam. Thank you,
madam. Thank you, Chandni.
That was also wonderful. Thank you.
Thank you, Dr. Chandni. So, is there any question? Otherwise, we will proceed to the valedictory and other thing. Okay. As there is no question, we are moving forward. Thank you, speakers, Dr. Bhanu, Dr. Rishikesh, and Dr.
Dr.
Chandni.
Sarad.
Yes, Dr. Manoj, boliye.
Some appreciation comment by me. Well presentation by Dr. Bhanu, Dr. Rishikesh, and Dr. Chandni Sinha, madam. Thank you. Keep it up to all of you.
Thank you, Dr. Manoj. Thank you very much. So, excellent presentation by all of you. Congratulations for wonderful. And first time I saw there was around 88 participants in the BGSS CME after a long time. I'm so happy today that finally we are going to touch again the 100 marks. We will keep trying our level best to encourage our members to join the CME and learn from the experts.
I will send you
I will send you the name of all the attendees, boss.
Thank you very much.
I have taken the snapshot of all.
So
I
nice
will
of you,
send you
JP.
that.
So nice of you. Thank you very much, JP. Thank you. So
Sharad
we are
sir,
moving forward.
Sharad
Yes.
sir,
Yeah.
just I need to add that I needed to keep the presentation for within 20 minutes, so I could not add a lot of topics. I hope others they take that into cognizance.
Yes. Sir. Thank you,
Rishi,
Dr.
you have done
Rishikesh.
wonders. Whatever
Wonderful,
time
wonderful.
was given to you, you presented wonderfully well.
Wonderful.
No
You
more
explained
regrets,
so well.
anything.
Yes.
Yeah.
You explained so well, Rishikesh. It was really mesmerizing listening your topic. Wonderfully explained. So now we are moving on. I am inviting our president, Dr. D.K. Singh sir, to please give the officially thanks to our the chief guest, Dr. Sabyasachi Das, and we will start the valedictory. Okay.
Thank you, Sharad. And first of all, I congratulate Professor Sabyasachi Das for his new assignment as a principal of Purulia Medical College. Congratulations, sir. Dr. Sabyasachi Das, congratulations, sir. And now I thank our moderator, Dr. Sahu and Dr. Jadan, sir, for nicely conducting the session. And again, I thank Dr. Bhanu Pratap, Dr. Rishikesh Jha, and of course, Dr. Chandni Madam for excellent presentation. Thank you all. Sharad, you may move forward.
Thank you, sir. And now I request Nishant. Hello, Dr. Nishant, are you there?
Yes, sir. Good evening.
Hi. Good evening, Nishant. Can you share the slides, the certificates?
Yes, sir.
Okay, thank you. So I will request our chief guest, Dr. Sabyasachi Das, sir, to give the certificate of appreciation to all the speakers. We will start with Dr. Bhanu, then Rishikesh, and Dr. Chandni. I request our chief guest. Okay. Okay. No, I request our guest of honor, Dr. and President BJSA, Dr. D.K. Singh, sir, to give the certificate of appreciation.
Okay, sir. Okay, sir.
It's okay, Bhanu again. No, okay, sir. I request our chief guest, Dr. Sabyasachi Das, sir, to give the certificate to Dr. Bhanu. Sabyasachi Das, sir, please give the certificate to Dr. Bhanu. Would you like to say something, Dr. Das? I think he is mute. Okay, Dr. D.K. Singh, you please give the certificate to Dr. Bhanu.
Okay, sir. I invite Dr. Bhanu Pratap Shran. Please accept the token of appreciation from the Society of Anesthesiologists, Bihar, Jharkhand. Dr. Bhanu Pratap, please accept it.
Thank you, sir.
Thank you. Sharad.
Dr. Nishant, please share the next certificate, Dr. Rishikesh Jha.
Yes, sir.
Okay.
Dr. Rishikesh.
Yes, hello.
Yes.
Thanks a lot. Thanks a lot for all the honor. Thank you very much.
It is again my honor to present the certificate of appreciation to our excellent speaker, Dr. Rishikesh Jha. Please accept Dr. Rishikesh Jha.
Thanks a lot, sir. Thank you. Accepted, sir.
Thank you. And now I present certificate of appreciation our Dr. Chandni Sinha. Dr. Chandni Sinha, please accept the token of appreciation from the Society of Anesthesiologists, Bihar, Jharkhand. Madam.
Please
Yeah,
share the
thank-
slide certificate. Dr.
Sir.
Nishant, please share the certificate.
Ishan, please post the certificate.
Is the certificate visible for Chandni?
No, not visible.
It is still Rishikesh Jha.
Yeah. No.
Okay.
Yes.
Yeah.
Yes.
Is it visible now, sir?
Yes.
Thank you, sir. Thank you.
Okay, madam.
Dr. Sabyasachi Das, sir, are you there, sir?
Yeah, I'm here.
Okay, I request you to please give the certificate to our moderators, Dr. Ashok Jadan, sir, and Dr. Rajendra Sahu, sir. Dr. Nishant, please share the certificate.
Dr. Ashok Jadon sir certificate, is it visible?
Yes, visible.
Yeah, it's visible.
Yeah.
So, Dr. Jadon, please accept the certificate.
Yeah, thank you, sir. Thank you.
Okay. Okay. And our next moderator, Rajendra Sahu. Dr. Sahu, I think you are available. Is it audible to you?
Yes.
Yeah. Okay.
Yes,
okay.
yes. Thank you.
I know
Thank you
that
so
you are
much,
very,
sir.
very dynamic person. Oh, I have seen you this many times. So please accept the certificate of Bihar Jharkhand Association of ISA.
Thank you, sir. Thank you. Accepted, sir. My pleasure. Honor, sir.
Thank you very much to all the speakers, moderator, chief guest, and guest of honor, and our president, Dr. D.K. Singh, sir, and all the esteemed member of BJSA. Thank you, Nishant. And now I would like to inform you all that there is a good news for all of you that on the 4th of September, that is Sunday, Jamshedpur City branch will be organizing a ISA-sponsored CME. This has just been confirmed by the National Secretary, Dr. Navil Malhotra, to me. And this is a very great moment for the Jamshedpur as well as the BJSA that the national sponsored CME has been allotted to Jamshedpur, and the date is 4th September. So I'm very happy to inform you all, and we will work on this, and we will in the next few days we will finalize everything and will inform all the members. So thank you very much to all of you. Now officially we are closing the program, but unofficially we will continue. And I would like to welcome our newly elected President-elect Dr. Gautam Saha sir and Dr. Ajay Kumar sir. Dr. Gautam Saha sir. Okay, he's busy, he just got the message. And Dr. Ajay Kumar, are you there?
Yeah. Thank you, Dr. Sharad.
I would like that Ajay Kumar sir.
Congratulations, Dr. Ajay.
Thank you, boss. Thank you.
Thank you.
I request Dr. Ajay Kumar sir to please give the vote of thanks.
I think Dr. D.K. Singh sir already given the vote of thanks to our speaker and chief guest. Again, I thanks to our chief guest, Dr. Sabyasachi Das sir, and our moderator, Dr. Ashok Jadan sir, and Dr. Rajesh Sahu. Especially, I thanks to our all speaker. First, Dr. Vanu and Dr. Rishikesh, your presentation is really very good. And Dr. Chandni, I know you are expert in this, especially nerve block and this ultrasound guided nerve block. So your presentation is very nice. And this type of, I think today is 88 participant. And previously I have seen only 30, 40, 50 around this. But today, I think today topic was very important. That's why maximum participant is in this CME. And this CME was very informative for all of us. So thanks to all speakers, all moderators, and Dr. D.K. Singh sir, our president, and Dr. Sharad, Dr. Nishant, and Dr. Motilal Das is also there. So thanks to all of you for participated in this CME program. Thanks everyone.
Thank you, Dr. Ajay. So it's almost 9. We will close in next 2 minutes. Anyone now the house is open for any suggestion, any remarks, feedback. Anyone can join, anyone can say what they want to say. Hello.
Sharad boss, I think with the quality of webinars that you are doing, we should invite other faculties in as well, so that the stature of the anesthesiologist at large, it increases.
Yeah, thank you, Dr. Rishikesh. We will keep this in mind when we will organize next time. Thank you. Any
And
other suggestion?
we should also go on recent advantage, what is going on, and the coming literatures that people are working on that. We should also just focus on that.
Yes, JP, you are right. Absolutely right. So as it हेलो और कोई सजेशन है कुछ कहना चाहते हैं कोई Okay, so it's almost 9. We are going to close the today 18th CME of the BGSA. I would like to thank you all the speakers again, the moderators, chief guest, guest of honor, and all the esteemed member of the BGSA. Thank you very much. Good night. Thank you very much.
Good night to all of you. Good night.
Good night.
Good night. Good night. Good night.
Nishan, thank you. अरे तुम
Good night to everyone.